Good evening, everybody. Welcome. We're just waiting for participants to enter the room. We'll give it a few minutes before Professor Ali will start his presentation. Thank you. Good evening, everybody. Thank you for attending tonight's Depression and the Use of Alcohol and Illicit Drugs. This presentation is presented by Associate Professor Robert Ali. Before we begin, I would just like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of this country. We pay tribute to their physical and spiritual connection to land, water and community, enduring now as it has been through time. We pay respects to them, their culture, and elders past, present and emerging. As I said before, Professor Ali will be presenting this valuable education event for us this evening. Professor Ali is a public health physician and a specialist in drug medicine. Until October 2016, he was a clinical director of Drug and Alcohol Services South Australia, a role he held for 30 years. Currently, he is a senior research fellow at the University of Adelaide. Robert is a member of the Australian National Advisory Council on Alcohol and Drugs, member of the Cochrane Alcohol and Drug Group Editorial Board, and the WHO Expert Advisory Panel on Drug Dependence and Alcohol Problems. Robert holds a number of university appointments, including visiting research fellow at the Australian National Drug and Alcohol Research Centre at the University of New South Wales, clinical associate professor in the discipline of pharmacology at Adelaide University, and a senior lecturer at the National Centre for Education and Training in Addictions at Flinders University. I'd just like to run through some housekeeping. If there's any technical issues with Zoom for any of the participants, please will you just have a look at the FAQs that we have in the chat feature. They should be able to help you. All microphones are on mute. This is in order for fewer interruptions. If you have any questions, you're welcome to submit it through the Q&A feature. Evaluation forms will be at the end of the presentation. And if you could all please stay on and complete this very valued information that we need to gather for this event. Certificates of attendance will also be sent out electronically following tonight's session. So I'd like to hand over to Professor Ali and thank him very much.
Okay, thank you. So good evening, everyone, and thank you for the opportunity of talking to you about depression and the use of alcohol and illicit drugs. I thought I'd start this session by letting you know that the National Drug Strategy Household Survey was released today. They must have known that we were going to have this conversation together. And I thought I'd just tell you about a few facts that we now know about the most recent data, which was collected in 2019, on what's going on in this state. Tobacco consumption has stabilised. We have about 1 in 8 South Australians who are daily tobacco smokers. We have also stabilised risky alcohol drinking. It's about 1 in 4, so 25% have consumed 5 or more drinks in one single occasion, and they've done that at least on a monthly basis. And we have about 1 in 7 that are using illegal drugs. Probably comes as no surprise to know that cannabis continues to be the most commonly used illicit drug. It's about 10% of South Australians that have used that drug in the last 12 months. But there are some other drugs there that I think you'll find puzzling and a bit surprising. We have seen a reduction since the last household survey in 2016 on the use of non-medical use of painkillers or illicit opioids like heroin. We've gone down from 4.3% to 2.9%, which is good. But we've also seen a reduction in methamphetamine use, down from 1.9% to 1%. That's use in the last year. That comes as a surprise to me because a lot of the people that I'm talking to continue to see presentations with methamphetamine, and that probably relates to the fact that crystal methamphetamine, which is the most powerful amphetamine, continues to be the dominant formulation of use. The really surprising one to me is the rise of cocaine. We now see 2.5% of the population have said they've used cocaine in the last year. Now that is quite a significant increase and is reflected nationally. But having said that, the use of ecstasy, cocaine, hallucinogens and ketamine are below national average. So we're still less likely to see those problems than our colleagues in the Eastern Seaboard, particularly New South Wales. But nevertheless, I think that what I've just said to you is an indicator that substance use continues to be an issue that's likely to come across your doors. COVID-19 has also added to the increase in substance use. The Foundation for Alcohol Research has recently conducted a survey which was nationally representative, looking at alcohol consumption in the light of COVID-19 and the restrictions that have occurred. Interestingly, they found 70% of the people who were involved in that survey reported drinking more alcohol, and a third of those were concerned about their own consumption or somebody else's consumption. So in that background, what I want to do today is really highlight for you the relationship between depression and the use of alcohol and illicit drugs, and specifically what you can do about it and how you can connect to the services that are available within the state. So let's start with a question, and I'll get you to bring the poll question up for me if you would. We know that depression is more common amongst people who are diagnosed with a substance use disorder, but I wonder what the relationship is in the reverse way. So what I want you to think about is, which of the following statements is true? A, that substance use disorder is less common amongst people who have been diagnosed with depression, or B, substance use disorder is more common amongst people diagnosed with depression, or C, there's no relationship between substance use disorders and depression. If I could get you to bring the poll up, and if you could enter your answer now. Okay, so it appears the vast majority of you believe that substance use disorder is more common amongst people who are diagnosed with depression, and that's in fact the case. I'll get you to close that for me now, if you would. So why would we talk about drugs and mental health? Well, people with mental health problems often find themselves using drugs as an effective short-term measure. And I like to think of it in terms of they might be wanting to escape reality, avoid remembering unpleasant history in their life, helping them to sleep, or trying to dampen down strong emotional feelings that they feel uncomfortable with. There's a variety of reasons that it does occur. And problems that can lead to dependent drug use are often related to emotional and psychological problems, as well as physical trauma and depression. I guess the question is, if there is the relationship, how common is it? And we know that depression is among the most common mental health disorders, and one of the most common mental health disorders you will be confronted with in your clinical practice. About 1 in 16 Australians currently experience depression, and 1 in 7 have reported an episode of it in their life. We know that depression is much more likely, somewhere around 3 to 4 times more likely, to occur amongst people who have a substance use disorder. And we also know that alcohol use disorders is nearly twice as prevalent in those with a history of a major depressive order. So the two are very much connected. And I guess that different drugs have different relationships. It would be good to actually think about the common ones that you're likely to see. So we know for alcohol, there are a range of mental health problems. Heavy drinking is associated with a significant risk of depressive symptoms. About 80% of people who've had ongoing heavy drinking will have that problem. And a significant minority, about a third of it, that's going to resemble major depression. Most of it goes away if they stop drinking. And it's often difficult for them to understand and see that relationship, because they often see that what they're doing is drinking to avoid the problem, but drinking is the problem. And a significant minority, somewhere between 5 and 10% of them, will actually require an antidepressant medication to manage that depression, even if they have been able to stop drinking. But it's not just heavy drinkers that have the problems. It's certainly people who have been drinking enough that they've been significantly intoxicated often have severe depressive symptoms associated with that. And in fact, we know that it's a risk factor for suicidal ideation. Alcohol-induced depression often lasts 2 to 4 weeks after they've stopped drinking, so it's not uncommon for that problem to continue. We also see problems with withdrawal, that they might have the alcoholic hallucinosis. DT is very uncommon these days with the advent of standard medication using benzodiazepines to manage withdrawal, and using a system of measurement of severity of withdrawal. In this state, we use the CWA. It is incredibly unusual to see that onset of that problem. Alcohol dependence, of course, is also associated with a range of psychiatric problems, and that could be anything from pathological jealousy through to paranoid delusions. And we also know that bipolar mood disorder is much more common amongst people with alcohol-related problems. So alcohol and mental health disorders have a very clear relationship, but it comes in many different faces and guises. Stimulants, on the other hand, often occur because of sleep deprivation. So we know that methamphetamine in particular causes a significant surge in noradrenaline. It increases your arousal, your wakefulness. And when you're sleep deprived, you often misunderstand what's going on around you. So you can become paranoid and suspicious about other people. During the crash, when they've stopped using methamphetamine, it's not uncommon for people to go through periods of anxiety, depression that's been associated with the crash. We can also see those expressions of paranoia extending into aggressive behaviour because they really do misunderstand what's going on around them. And in fact, in high doses with prolonged sleep deprivation, toxic psychosis with persecutory delusions are very, very common. It's not uncommon now to see people detained in our mental health services with a question of methamphetamine psychosis following intensive crystal meth use. Opioids have a different relationship. People who have been using intensive opioids to the point that they're dependent, whether that's heroin or prescription opioids, are much more likely to have depression. And that often, unfortunately, leads to suicidal ideation. In fact, heroin users are significantly more likely to commit suicide than age-matched counterparts. It can be also that the relationship with opioids is structured around post-traumatic stress disorder. So often they've seen serious events in their life which has led to post-traumatic stress disorder. And that could be anything from witnessing a death of a friend or partner from overdose through to very violent altercations that relate to drug situations, so drug debts, etc. A lot of those situations in terms of depression resolve when they're in treatment, and we find in methadone and buprenorphine treatment, often in the first month of care, the symptoms of depression that we would have seen in initial presentation disappear. But increasingly now, clinicians are recognising the importance of looking particularly for post-traumatic stress disorder, as it's often an underlying antecedent that's been involved in the use of their heroin, and we need to actually manage that if we're going to get them to move on. So I guess the question is, with the high rates of coexistence of mental health disorders and substance use disorders, routine screening is a really important thing to do, particularly if you're presented with cases where you think there's a mental health disorder, because we know that screening and detecting the substance use disorder can enable a very effective intervention for both. The question is, how would you go about doing that? And I thought a way that we might be able to work our way through this discussion is to start by thinking about a case. Paul, 55-year-old man, attends your practice and he is known to you. He appears hesitant when you ask him, how can you help? And he says, oh, I just need something to help me sleep. Paul's recently moved back to your practice. He'd spent some time away from your practice. Let me go back. He's now living with his mother because he's separated from his wife. He has two adult children, sons that are in their 20s, and they're both living interstate. And until recently, he was a sheriff and was quite successful at his job. But with the COVID-19 restrictions and the lack of custom, he's been unemployed and now has no income. So when you assess him, he appears tired and unshaven, and he's dressed in an oversized tracksuit. He's put on a bit of weight. Initially, he answers you poorly, and he has poor eye contact. Since he's ceased work, his daily activities now is just binge watching Netflix. He used to enjoy playing golf, but he's lost interest in doing that. He said that the relationship with his mother's tense because she wants him out and wants him back with his wife. And he's able to get off to sleep, but wakes up and then can't get back to sleep. And when you ask him about his substance use, he tells you that he stopped smoking a decade ago, but he likes to drink. So in that context, I guess the question is, how would you assess his mental health state and how would you assess his substance use? What I want to do is to walk you through a process around these two areas, and then we'll discuss that in terms of, does that fit with the way you would approach it? So we know with depression, there's a feeling of sadness and emptiness and irritability of mood, and it's often accompanied by both physical changes and cognitive changes. I think of it as a cluster of three, that there is issues around mood, issues around thinking, and issues around their physical and psychological mobility. And those symptoms are usually experienced on most days, and they're enduring. They've been there for at least 2 weeks, so it's not something that has been there for a short period of time. And with ICD, we classify those patterns over time to determine which best fits the clinical presentation. We know that there are personal protective factors that give us resilience to prevent the likelihood of becoming depressed. And having supportive family and friends, being activated, having exercise, nutritionally sound, sleeping well, having access to work and feeling financially stable, outside interests and a sense of worth, all of those things protect us from the likelihood that we will experience depression. But we can see that our case has many of these personal risk factors. Divorce or separation, financial stress, a question about drug consumption that we're still not really clear about, only that he likes to drink, loneliness and isolation. And these things actually will connect in a way to increase our vulnerability. To diagnose depression, we need a period of almost daily depressed mood and diminished interest. And that's got to last for some time. And it's usually associated with things that will be relating to concentration, sense of worth, and changes in appetite and your psychomotor ability. So I can see that I've been asked, are notes going to be available to print out? And the answer is yes. I'm sure that Satmir will be more than happy to share a PDF version of this so you can get all of the notes as well as the links. So in terms of the towers, you can see that your thoughts and feelings are in the middle, and that senses of I'm a failure, or it's my fault, I'm worthless, or feeling unhappy and overwhelmed. And that can often be connected to behavioural inactivation and physical inactivation. So in DASA, when I was there, we would use the K10 to assess severity of depression. I know that in general practice, many of you will use the DAS21. There's no real preference of one over the other. Each is equally as good. But it's important not just going through those questionnaires, but also inquiring about severity and duration of the symptoms to get an idea about, is this really troubling them, and how long has it been there? Is this an enduring problem? And what kind of impairment it's causing to them in their life, and if they are having thoughts of taking their own life, whether they do have suicidal ideation. I think it's also important to try and separate out a reactive depression from a bipolar mood disorder by looking for whether there have been any episodes where there's been either hypomania or mania where they've had increased activation, elevation in mood. So it's important clinically to separate those two aspects. I think it's also important to check that there isn't a medical condition that's causing the problem. And you can see that there's a variety of common conditions here which you would be aware of: cardiovascular disease, diabetes, and dementia. Dementia unlikely in this man, but we want to make sure of the cardiovascular disease and the diabetes, but also looking at thyroid function and the risks of Parkinson's disease. And of course, there's also the issue of medications, that some of those can cause the problem. As he's been a non-smoker for some time, Champix is unlikely to be a contributor. So the DAS-21 provides an assessment of depression, anxiety, and stress, and provides a risk range from normal through to extreme for all of those conditions. And the Kessler, the K10, similarly provides a score which enables you to differentiate mild, moderate, or severe. So you've done the K10 on Paul, and his score comes back at 26, which is in the mid-range of the moderate range for K10. My question to you is, would you see him as an appropriate candidate for an antidepressant? A is yes, B is no, and C is not sure. I'll get you to put in your score now. Okay, so just over half of you, or sorry, exactly half of you said you're not sure, and then we're equally split. It's no slightly more than yes. So there's clearly a difference of views on this. I'm interested, those of you who said not sure, are you able to put into the Q&A the reasons that you're not sure? So Beck has said quantity of alcohol. Kathy said, I need a bit more history. Okay, so several of you have said more history, not suicidal, first visit, need to assess. So the uncertainty is coming through about trying to also get some more information about previous medications. I think all of those are interesting and important points to consider. What about those of you who said yes? Some of you that said yes, you would prescribe an antidepressant. It looks like the yes people are being a bit shy. I'm not able to see anyone who's put a yes forward as answering yet. So I think my position would be to hold fire on this as well. I think I need a bit more information. I'm always puzzled by people who say yes, that they like a drink, but without knowing what that means. It may be a red herring. It may be absolutely nothing to do with the reason for the presentation, or it might be a significant contributor. So I would want to inquire about that in some more detail. And I guess I've given you a brief potted history, but I would be also wanting to explore with him exactly what he's tried already to help himself, and whether or not there's been any success in mitigating that or not. So we'll move on to the next slide. So often thinking occurs that mental health problems lead to alcohol and drug use, and the alcohol in this case might provide a temporary relief of the symptoms, but then the mental systems return, so the person then increases their alcohol use, that increases their tolerance, and so the wheel turns, that it then becomes you chasing yourself, that the temporary solution turns out to be part of the problem. And I think it would be fair to say that that's often thought of as the only possible route, but it's actually a bit more complicated than that. There are a number of possible explanations about why you might have a problem of comorbidity. It is possible that the mental health condition leads to the alcohol or drug disorder, but it's equally possible that it could be the reverse. Sometimes it can be an indirect causal relationship, and sometimes it could be just a common factor that's causing both of them to occur, which is actually the root cause of the problem. Diagrammatically, the three possible scenarios are represented here, where you can see it could go in either direction. Those indirect causes are usually some intermediary factors. So we know that if you have a mental health condition, you might be not doing particularly well at school in early ages, and that is likely to lead to difficulties with employment, which may lead you to move into using substance use. And equally, the reverse can hold true. So the intermediary factors could go in both directions. But we know that there are a variety of psychological and health reasons that will also find common ground for both those substances, both those disorders to occur. And whether it's a genetic predisposition or the sociocultural context in which you live, there can be a common antecedent that can cause both. Getting that relationship, understanding that, there's been a lot of discussion and debate about, is it really important? Do you really need to know which comes first? In my working life, I have found it helpful because it often points to the mediating solution. So I've talked before about post-traumatic stress disorder and how that can often be an antecedent to substance use disorders, but it can also be an intermediary factor. So understanding the relationship helps me sort out what I'm going to do. I like to suggest to you that using an instrument that was developed by WHO, the Alcohol, Smoking and Substance Involvement Screening Test, is a good, quick, easy way of screening for substance use disorders. It's an 8-item test. You can do it electronically as a web-based assessment. There's a PDF download. We're having conversations with the medical director at the moment about the potential for it to be included in the battery which is on medical director. But it's intentionally been designed for primary healthcare and has been found to be valid in those settings. But it's also been used in mental health settings. So people who've got coexisting mental health disorders, it works with them too, and it's cross-culturally neutral. The benefit of it is it screens for all drugs, legal and illegal. And the reason I say that's a benefit is that often as clinicians, we make determinations of likelihood of something happening by appearance. So I'm mindful of a guy that came to see me with a significant heroin problem that had never been asked whether he'd used heroin because he was still functional, he was working, and it had never crossed the mind of the other clinicians that seen him that that was actually a possibility. It does that by asking a question of in your lifetime, and that can be quite helpful to screen out risk of any substance use, but it then goes on through those questions to assess severity and stratify that in terms of low, moderate or high risk, and a specific purpose-built intervention is then connected to that, which helps provide solutions to what might be substance use related problems. The good thing about it is that we know that people that are in the low risk group, just giving them information and feedback that they are at low risk increases the likelihood that they will stay in that level. And I'm sure that many of you, when you encounter somebody like Paul, our case, who's a recovered smoker, that we reward them for the success by congratulating them. Those kind of public affirmations have a good effect of maintaining low-risk behaviour. But we also know from the research now that people who are in the moderate risk group actually respond effectively to brief feedback and a brief intervention. And the approach in the assist has been developed which enables that to occur. People who are in the high-risk group, however, they need a more detailed assessment, and that might be you then providing a more detailed, structured clinical intervention than just brief advice or a brief intervention. Or if there's someone that you think is beyond your skills and resource capacity, they might be somebody that you would refer on to a specialist agency for ongoing management and care. So it's nice that it's able to stratify risk, and it does that through asking questions which directly relate to the risks and harms associated with substance use. As I said, question 1's a screener question of ever use. We concentrate on the last 3 months because that's more salient to behaviour, and in Paul's case, that would be quite important because the onset of this behaviour has been relatively recent. Concentrating on the frequency of all substance use that he's ever used in the last 3 months, looking at the desire to use, intrusive thoughts, cravings to use, if there have been consequences, that could have been health, social, legal or financial, whether they've been able to do things that would ordinarily be expected of them. And then we then go back to lifetime questions, but stratify them in risk in terms of recent, so is that last 3 months or has it ever occurred in your life? The reason we use them as lifetime is because they're more sensitive to picking up potential problems, particularly concerns by others. It's often other people around us that express concern while we're still uncertain whether it's a problem or if it is, that we actually do we want to do anything about it. So that's actually quite a useful question to ask. And the other one that's useful is attempts to cut down or control use, but unable to do it. So I would call that loss of control. So that's a conditional statement where wanting to know, did they try and did they fail? And of course, injecting behaviour is always a risk, and we always give messages about risks of bloodborne virus transfer, and particularly now in the area of hepatitis C, that we have an effective medication intervention. Screening for that is also quite important. So the intervention is linked around the risk, and as I said, it really is aimed at that moderate risk range group, and it's connected to a feedback card which we are able to provide you, and it doesn't take very long at all. For a single substance, it's typically around 3 to 5 minutes, but if they've got two, which might be one legal and one illegal, then it might go on for 5 to 10 minutes. It uses a framework which is has the acronym of FRAMES. That was developed by Bill Miller, who's the architect of motivational interviewing. He recognised that not everybody who has a problem is concerned about it, and even if they are concerned about it, not everybody wants to do anything about it. So he was the architect of motivational enhancement therapy. And Martha Sanchez-Craig is a psychiatrist from Canada, who has been able to connect behavioural aspects to motivational aspects. So we provide personalised feedback around what the score means to the person. We give choice back to them. We say what you want to do is up to you. I'm just here to help you. And then we give some simple advice about how to reduce risk. Choice is always good. We have some self-help materials which can help identify ways to cut down depending upon which the particular risk is. And as I'm sure you already do, we know that an empathic style of counselling has a much greater impact than telling people what to do, and giving them the can-do attitude that it can work is likely to also enable that. So before we do the poll question, I just wanted to ask you a question. How many of you now are already using the assist? If you are, could you just put in a yes for me in the Q&A section? Okay, so it looks like a couple of you are using it at the moment, which is good to see. So some of you will be quite familiar with what I'm talking about. I'm going to move into our second poll question now. When you did the assist, he scored for yes to tobacco as a lifetime, but nothing since the last 10 years, and no to all other drugs. But he did score in the moderate risk range for alcohol. In fact, he scored right at the top end. He's almost in the high risk score. So with somebody that's scoring so high for alcohol, is he somebody you think you need to send on for specialist referral? I'll get you to answer the poll. A is yes, B is no, C is not sure. Get you to answer put your answers in now. Okay, so we've got 48% of you saying yes, you would send him on, 22% no, and 30% not sure. Okay, so just interested to hear from the not sures. What's the uncertainty in your mind about whether you would or you wouldn't? Can you type in something for me in the Q&A, please? Okay, so we're getting some answers coming through here. We've got, depends whether medication may be indicated to help with, does he need a detox? Someone said I'd provide him feedback and discuss benefits of reducing alcohol and add exercise and then review in a week. If it's uncomplicated, he's motivated, we'll commit to regular reviews. It might be something we can manage together. So it's sounding like the feedback that I'm getting is that, well, it depends. Not sure whether he's at risk for withdrawal, not sure whether he's interested in stopping, not sure whether he'll respond to what I can do. So he may need referral, but he may not. And for those who said no, is there anything else you would like to add to the not sures that you think hasn't been included in the answers that you've given? Okay, so we've had explore what he likes drinking means to him. I think that really is an important question, and that's something we're going to come back and talk about a little bit later in the presentation. So I like that because that can be quite a helpful key. Someone else has said drinking more is a maladaptive coping style, and I'd like to see if we can help by other means to treat the underlying sense of worthlessness. So this person saying, from my point of view, I think the primary issue is the sense of worthlessness, and if we can manage that, will everything else fall into line? Okay, so I guess the other group that we haven't heard from is the yes, I would send for referral. Anyone who answered that, if there is something you'd like to raise for discussion, could I get you to type that in for me now? Okay, so someone said any help is good and DASA is a good resource. And having come from DASA, I would completely agree with you. DASA is a good resource, particularly to draw down for complicated cases that are difficult to manage. So it sounds like in the group there's divided opinion about whether you in your clinical practice would refer this person on, and the uncertainty is about just trying to get an understanding about capacity to control and getting more information. And for those that aren't, focusing in on those meanings related to his enjoyment of drinking, and then a view that we also need to deal with a mental health issue, and maybe by dealing with that, then the drinking problem will disappear. So let's move to what sort of other question you would ask. And I would agree with those of you who had this in the back of your mind, that somebody who's on the border of that threshold of this is quite a serious problem, probably isn't going to do as well with just a brief intervention without having a better understanding of their particular circumstances. And it really is critically important that you get an adequate drinking history. You need to know from them on a typical day how much would they drink, how many days of the week would they drink. Now, the Audit C likes to think in terms of 6 for men and 4 for women. For those of you who are concerned about the risk of withdrawal, that bar is a bit low. I would be more concerned about, is he drinking north of 80 grams of alcohol a day? Definitely if he's drinking more than 100. So in that, heading around 80 grams a day, he's likely to go through mild withdrawal. Not all withdrawal needs to be managed in an inpatient setting. Most of it can be managed in outpatient settings. And in the context of his social circumstances, that's something that could be managed. But let's go on in terms of how do you assess consumption. We know that a standard drink is 10 grams of alcohol, and we know that it's now mandatory law that all beverage containers have the number of standard drinks on them. And we know for wine, there's a huge variability in the standard drinks because wine can go from anything from 11 to 12% up to 16% alcohol per volume. We also know that when people pour a drink themselves, they rarely pour a standard drink. So a mid-strength wine, typically 100 mils, is one standard drink, 10 grams of alcohol. And if you're in a restaurant and somebody poured you 100 mils of wine, most people would look as if that's not enough, because in our mind, we've been trained to drink, to pour somewhere between 1.5 and 2 standard drinks. So when people are saying that they drink at home and they pour their own wine, find out what size glass and how big they fill it. That'll help you understand. If you know 100 mils is a standard drink, then that will help you to work it out. There's also a really helpful online drinks calculator, which the Victorian government have developed, and I've put the URL there. It covers all beverages and it allows you to quickly tot up what it is. So if you're not used to working these things out in your head, that's a really helpful asset to be able to draw down on. If you think that there's a risk of withdrawal, test it out. Ask the question, when did you have your last drink? And what usually happens when you stop drinking? Do they get the shakes? Do they get intrusive thoughts about the need to drink? Have they had withdrawal problems in the past? It can be really helpful to understand and predict risk, particularly if they've had a history of withdrawal seizures. It's quite important that that gets managed, and that would be a threshold issue for me, thinking about moving the person on for care by DAS or in the withdrawal service. So when they had their last drink is also helpful to understand how big the need is. And if they've had a drink before they've come to see you, that's giving me an indication that actually drinking is really getting to be quite of a problem. If they've never tried to stop drinking, so since this episode they've had daily drinking and they've moved the time of commencement of drinking forward, that they're now starting to drink earlier and earlier in the day, it can be helpful to ask them what they're like in the morning before they have their first drink. How do they feel? We know the saying, hair of the dog. Hair of the dog is actually raising your blood alcohol level to steady your nerves and to stop that internal tremulousness or shaking. So I think the key point to draw out of the discussion from the poll question is, you're absolutely right. You do need to have some sense of, can he do it? Will he do it? What help does he need? You do need to think about the relationship to the mental health issues and which came first. But you also need to get a sense of how serious is the drinking problem. And while the assisters flagged he's potentially a risk, for that upper end person, I'd also be asking this drinking in those 3 quick questions of how much do you drink on a typical day, how many days of the week do you drink, and how often do you drink. I would move it up to 8 or more drinks a day. And but mindful in your mind, we're talking about standard drinks, which is 100 mils of wine. It's not a typical pour of 2 standard drinks. So addiction is a complicated consequence of repeated exposure to drugs. And it's a significant rearrangement of thought processing. It's chronic and regrettably often relapsing. And it's very much associated with the compulsive need to use a substance, even though you know it's causing you a problem. So you discount the adverse consequence and seek the reward of having that substance, and you have lost control. That's very much driven by changes in the processing that's occurred in your midbrain, where you have now ranked this as a higher need than the executive functions that would ordinarily rule it out as potentially risky behaviour. In terms of diagnosis, the recent release of ICD-11 has really recast and reconceptualised ICD-10. They now connect it to 3 main axes, and it only requires 2 of those to be positive for you to make the diagnosis. You can see that with the exception of the physical features, the assist covers these 2 dimensions. So loss of control, your inability to cut down or stop using, is one of the defining characteristics. And that's often associated with intrusive thoughts, desires, cravings to use the drug. The next one is a higher priority over other activities, that it becomes more important to you than other things that used to occupy your life. And that is often associated with doing it even though you know it's causing you a problem. And the third dimension are the physiological features. Tolerance, that's the need to take more of the drug to get the same effect, or the onset of withdrawal, that when you stop the drug, you get a defined reproducible withdrawal syndrome. So with Paul, I haven't given you sufficient information to make an assessment of whether or not he does have a diagnosis of dependence. The physiological features of dependence were starting to become evident, that he had noticed that he could drink more than he used to, and that he enjoyed that feeling of intoxication. The priorities, you would have noticed, he identified as attributed to the number one thing in his life now was watching series on Netflix, but that was usually with a drink in his hand. And sometimes it can be difficult to disentangle which is the driver in that, but he would often be seen with alcohol, and would be watching Netflix all day. And he denied impaired ability to control use because he said he hadn't tried. There was no reason, and that paradoxically has the same implications for somebody who has tried and succeeded. So somebody who was a smoker and gave up on their first attempt was able to control their use, was able to cut down or stop using. That, in terms of diagnosis, is no different to somebody who's never tried. Because the thing is, we don't know what will be the consequence if the person had tried. So for Paul, I would have said that he had crossed the threshold and was showing symptoms of dependence. He had had this behaviour for a month and had been on a daily basis, but I would have placed him at the mild end. So I didn't get the sense that there was a risk there of significant withdrawal, but I had noticed that he was definitely increasing the amount that he could drink, and that was connected to two things. He increased the rate at which he consumes, so people who have got tolerance tend to drink more quickly than those who don't, and their satisfaction when they feel they've had enough is set at a higher threshold. So I've said quite a bit around diagnosis there. Does anyone have any questions that you want to ask me about that before we move on? I'll just give it another second or two, because there seems to be a lag between the time you post your question and I see them. I don't want to rush on, but if there's no questions, I'm happy to move on. doesn't appear that there are any, so I will move on. As I've said, there's some complicated neurobiology involved. Alcohol affects virtually all the brain systems, and it can be difficult to define which system contributes most, from those people who are able to control their drinking to losing that control. And because of the complexity of it, I think that's why there's been so many different approaches to medication that have been used. I want to give you a composite approach on how to think about this, that I see it in terms of stages, and I see those stages being linked to potential medications that may be helpful. I think that some people enjoy the experience of being drunk, and we would call that reward drinking. Whereas some people don't like the negative feeling that occurs once they start to have repeated withdrawal if they don't have access to continue drinking. So instead of rewarding themselves with a drink, they drink in anticipation of preventing withdrawal symptoms. And the third group are those that have intrusive thoughts or preoccupations about drinking. And those cravings often lead to a lack of resolve, where they may be having little discussions with themselves about will I, won't I, but the will eventually wins because they find a reason or a way to do it. Now, those stages are seen, the NIAAA in the United States have developed this composite addiction model, which they see as an evolution of discrete neural circuits, and relates to restructuring and rewiring within brain chemistry, which has an influence upon the reinforcing value of drinking. In my clinical experience, I don't necessarily see them as evolutionary, that you need to go through each stage. But I do definitely identify with people having one of those as being a driver for when they are dependent about why they continue to drink. So that reward-based drinking is usually mediated by the endogenous opioid pathway, and that has a direct alcohol. It activates the mesolimbic dopamine circuitry, and so you would expect that opioid antagonists like naltrexone should have a role in reducing those desired effects of intoxication. So it is a way of interfering with the GABA circuitry in the ventral tegmental area, which ultimately leads on to in the nucleus accumbens and the release of dopamine. From the meta-analyses that have been done, I think there's support for the use of naltrexone. It has been registered by the TGA specifically for treatment of alcohol dependence. The effect size is small. And the question is that because the endogenous opioid pathway is only a minor part, or does it reflect some heterogeneity? And we know that there is a CYP that codes for alterations in that pathway that have a profound influence on the effects that alcohol have. At the moment, that's a research interest. It's not a clinical or a practical application. But as precision medicine evolves in this area, in the future, it could well be that you'll be able to do genotype testing for that SIP to determine whether or not opioid antagonists would be helpful for a person who is a reward-type drinker. But we know that if it is a reward-type drinking pattern, this is the medication that's most likely to be effective. If you're going to use naltrexone, we initially start with a lowish dose, so half a tablet, and we aim to get them as 1 tablet a day. What it does is interfere with enjoying being drunk. So it's not really aiming for somebody who wants to not drink at all. But what it does is to reduce their enjoyment of intoxication, and it can be used safely while someone is drinking. Now, clinically, NIAAA have done studies which have looked at, instead of taking naltrexone daily, you take it only on the days if you intend to drink. And it modifies the enjoyment from your intoxication, and they found that to be clinically effective. If you are going to use it, it needs a significant duration of treatment, around 6 months, and the TGA insist on a connection with psychosocial interventions. I think one of the take-home messages I would give you is that drugs on their own don't work. You have to give medication with a behavioural intervention, and if you're not going to provide that psychosocial intervention, it will greatly undermine the effectiveness of the medication. So the side effects, obviously, if they're on a prescription opioid, either for treating opioid dependence or they've got opioid medication for some other condition, that's going to precipitate withdrawal, so it's a contraindication. The other problems usually disappear. Dizziness and appetite and sleeping difficulties would be the ones that I see most commonly, and they usually disappear quite quickly. I haven't seen much of an interaction with depression and irritability, but it is recognised on the product information. Stress-released drinking, so this is anticipating of a negative emotional state. Let's call that withdrawal, anxiety or depression, can be a potent reinforcer and can drive escalation of consumption. It works by a different neuronal pathway. The extrahypothalamic corticotropin releasing factor mediates it, noradrenaline and dynorphin and endogenous opioid systems. They're all interconnected and seem to be related to this. The medication that seems to work best with this type of relief drinking is acamprosate, and that is a GABA-A agonist rather, and an NMDA antagonist. What it's doing is correcting or balancing a glutamate GABA imbalance. It's one tablet 3 times a day. It's moderately effective. This one is aimed at abstinence. It's not aimed at controlling drinking. And it is best to start while they're still drinking or during the detox phase if they need to go through withdrawal management. Probably need to give it a little bit longer, about a year would be optimal care. Interestingly, the persistence of benefits even after they stop. So often we get people who stop this prematurely, but there have been several studies that have shown enduring benefit long after the person has stopped. When we look at effectiveness of the medication, we can see that numbers needed to treat for naltrexone for abstinence are much higher because it really doesn't work as an abstinence drug, but it, in terms of preventing relapse to heavy drinking, lower numbers and has a greater impact on reducing heavy drinking days, whereas acamprosate very much more likely to gear towards abstinence-oriented. The numbers needed to treat aren't all that impressive, but they nevertheless are effective with the right candidate. Now, I've also put on the bottom of the slide disulfiram, which I haven't included in this table because there are insufficient studies for me to actually populate the table. As you know, disulfiram is a drug that interferes with alcohol metabolism. It causes an interference of alcohol dehydrogenase and causes acetaldehyde to build up in the body, which is a toxic metabolite, and that makes you feel horrible. It gives you nausea, vomiting, facial flushing, headache, blood pressure goes up. Some people have alcohol dehydrogenase deficiency genetically defined, more common in Asian populations, and you will see that they get a very red flushed face when they've been drinking alcohol. Well, that's an anti-abuse effect. This is if you like, a negative contingency management approach. You take the medication because you know if you take it and you drink, you will feel unwell. So it's to avoid you commencing drinking. It's not on the PBS, so it's expensive. It's about between $60 and $80 a month to prescribe it if somebody's going to take it. It is effective for those who like that kind of protection, that they know there's no point drinking and it acts as a deterrence, but it does have a cost factor that's worth knowing about. The last group that I talked about was that the cravings group. They're either reward-induced or relief-induced. So the drug exposure has been linked to something of enjoyment, or it's been linked to something that removes a negative emotional state, and that could be anxiety or depression. So they have intrusive thoughts about having the drink as a reward or to block an adverse consequence. Unfortunately, we don't have clear medications that work with this condition. But we do know for people that have got coexisting mental health disorders like depression, SSRIs work. So we know that it has been conceptualized as a stress-induced relief. It definitely works better with people who have developed their drinking problems at a later stage in life, in their 40s, when they have significant psychosocial morbidity and there's low family loading. So there's not a strong family history of a substance use disorder. So I guess the question that I would ask is, we've already talked about the idea that some of you have thought that I'd get him to control his drinking, and we're saying withdrawal is not not an issue here. Would you have a preference to introduce one of these medications that I've identified? And if so, what would the reason be? I'm just interested if you could give me your thoughts on that. Okay, so we've had a few people answering already, and SSRIs have come through as an issue. Some have had experience in using them and haven't used anything else. Some have had not experience in using any of the other drugs. Some are saying that you'd combine an SSRI with psychotherapy. Some are saying that we'd think about the alternative medications in the future. And we've had some people saying that if a medication was indicated, that would be a reason to refer, that you'd see that as something outside of your domain. I think this case is an interesting case because there is a complicated relationship between his life situation and his drinking situation. He's had some stresses, hasn't he? He's had a failed marriage. He's been unemployed because of the situation of the shutdown through COVID. He has returned to his parents' dwelling, which probably reflects a lack of financial resources. He's now spending a lot of time in front of the television. We've seen that his drinking score has gone up, and he has not been drinking enough that he's causing withdrawal, but he certainly has noticed that his tolerance to alcohol has increased. And so if I was going to use one of these medications, then I would be thinking about where does it fit? What does he want to do? We know that it's possible to differentiate his goals and to help us assist us in thinking about which medications we might want to use. Ordinarily, I guess I would approach it in the first instance about seeing whether or not we can manage it behaviourally. But if I was going to think about a medication, I would be thinking about, well, what's his goal? Is his goal to reduce or stop drinking? Because that's going to have a significant influence on where I'm going to go with this man. So he's been drinking on a daily basis, and he's been drinking some days 80 grams and some days a lot more than 80 grams of alcohol. He's never got much above 150 grams, but he certainly is drinking to intoxication, and he enjoys being intoxicated because it helps block out the problems that are in his life, the marriage, work, finances. So, and he's a man who has expressed interest in wanting to get some help to help him sleep. And I guess the axis here is about reframing that, about what might help him sleep. And we know that alcohol significantly interferes with sleep-wake patterns. And we know that it also significantly reduces the quality of sleep when sleep does occur. So not only does it reduce quantity, but it also reduces quality. So my approach for him would be initially to develop a mental health treatment plan. And of course, the therapeutic relationship that you connect with him is essential to enabling that plan to be successful. So an empathic, caring, understanding relationship which has milestones of where you want to go and a pathway for care is quite important. There are self-help resources that are available, not just for his mood, his depression, but also for his drinking. So it's possible for him to go to services like Hello Sunday Morning, which is a web-based peer support network that can be helpful. In South Australia, DASA has created a website called Know Your Options that has self-help material and resources for cutting down and stopping drinking. And on the mental health side, Beyond Blue has got materials and resources that can be helpful. So I want to connect him into self-help resources. I think it's critically important that we also make a contract about stopping drinking. So often when people hear that drinking might be contributing to the mental health problem or compounding it, what their goal is to cut down. And I'm very keen to clarify with them that we do need a period of abstinence so that we clear the decks and can be confident that we understand what is going on. You might well be needing to do some investigations to determine whether he has any underlying liver problems. In Paul's case, there weren't, but that would be important to make sure there wasn't any contraindication to going back to controlled drinking. But controlled drinking is something I can come back and talk to you about at another time, but it is also a strategy of evolved exposure with clear rules. And it requires a period of abstinence to enable that to occur. We know that behavioural activation is critically important. We know that he's essentially lost his lifestyle. So he's lost his social network at work. He's lost his social network through golf. He's now sitting on a couch trying to avoid discussions with his mother because he doesn't want to get into the inevitable downward spiral of why don't you sort things out with his wife. So he's retreating into his own shell. And we know that physical activity is critically important to reactivating mood. And we know that it's also critically important for reducing the centrality of drinking. So good social networks, regaining employment, and regaining a connectedness with the world in healthy lifestyle is greatly going to improve and support the resolve to stop drinking. But as with all of these plans, you need milestones and you need to be able to come back and assess him. And during the course of your feedback as we've gone along here, many of you have identified the importance of monitoring and review. If that depression persists, even though he has been able to stop the drinking, and ordinarily we would expect that mood would start to lift within 2 to 4 weeks, then you could provide psychological intervention, either yourself or a referral to a psychologist for some CBT. If he hadn't settled within 4 weeks in terms of depression, I would then think about adding an SSRI. Citalopram is the one that I would ordinarily use, but that's just a personal preference. Or you could, if sleep really was the central problem, you can use mirtazapine. Mirtazapine is quite good if sleep is the problem, and you can start out at a lowish dose, around 50 milligrams at a night time, and that will help with the sleep as well. Critically important that you've got regular follow-up and review. It really is important that you monitor both his mood state as well as his drinking. Now, the assist that I mentioned before can be used as a repeated measure. That repeated measure is every 3 months. The window of the questioning is around 3 months, so it doesn't help to redo it in a shorter window. But if you've been thoughtful about the drinking history, so you know the quantity and the frequency, you can monitor that. You might need to get other significant others involved, but in the case with Paul, I'm not sure that is necessary. You might need to also be mindful of the connection about the wife and the employment. Now, one of you, Carol, has identified about lowering seizure threshold with mirtazapine. Quite right. In the case of Paul, he hadn't had any withdrawal seizures, and he hadn't ever felt a serious discomfort on stopping alcohol in the past. But he's in a different space because he has been drinking. His escalation has occurred over a relatively short period. My experience of withdrawal seizures are that it's very uncommon under 120 grams of alcohol a day, unless they have also got epilepsy as well. I see a lot of patients that confuse the two. They thought their withdrawal fits were epileptic seizures, not caused through or related to alcohol. So sometimes people get a bit confused about saying that they've had a history of epilepsy. But yes, I think, Carol, you're right. You do need to be mindful of it, but in the quantities that he was drinking, I wouldn't be concerned about that, particularly if we've been able to successfully get him to stop drinking, but that problems with sleep had persisted. Okay, so you monitor him, you look at his drinking, you look at his mood state, and if you felt after regular review, and I would have expected you to have spent somewhere around the 2 to 3 month mark, if you felt he wasn't responding or it was getting worse, then by all means you can think about that actually does need specialist referral. If he was going to go back to wanting to have drinking again, I'd be thinking about controlled drinking, and I'd be thinking about whether I would add naltrexone to reduce the enjoyment of intoxication. But that's well down the track for this guy. At this stage, I think the main thing that we're wanting to do is to raise his mood. I think it's also important that we flip it the other way. And for those of you that are treating people that have got significant coexisting mental health disorders, those mental health disorders alcohol and drugs can have a direct impact on their medication. So we know that cannabis, alcohol, and opioids augment the sedative effect of tricyclic antidepressants and benzodiazepines. So they are very much not a good mix. I know we use benzodiazepines for managing alcohol withdrawal. I know that you might want to use a small dose of benzodiazepines in assisting an outpatient opioid withdrawal, but we need to be mindful about the interactions. The other one that I just draw to your attention is both nicotine and cannabis, that both of them may induce metabolism of antipsychotics and hence reduce their effectiveness, and something that we need to monitor. They may also lessen some of those, what they would see as nuisance side effects, the flatlining of life, the modulation being removed. And so often what they enjoy is to take those drugs to reduce those side effects. And that may be that that's part of the reason why you have such high rates of nicotine and cannabis use amongst people with psychotic disorders. It's one of the things that I know mental health are now actively moving towards encouraging people stopping smoking, and we've been working with them on strategies to reduce or eliminate cannabis use, because it can really interfere with people that have major depression or schizophrenia. So if you're going to send people to DASA, or you need advice, there are some opportunities that are worth knowing about. There's a drug and alcohol clinical advisory service that's available 7 days a week from 8:30 in the morning until 10 at night. I've got the number on screen, and of course we'll provide you the handouts of the talk so you can get access to it. You can get immediate clinical advice 7 days a week, but if you want to talk to one of the addiction medicine consultants, at the moment they're short-staffed and really busy, and it may take up to 24 hours for them to get back to you. But before then, you can get interim clinical advice from one of our medical doctors that works in the clinic. If it's a less urgent inquiry and you want an email answer, I've put the email address on the screen as well. Now, I'm sure that all of you are aware of the Alcohol and Drug Information Service, 1300 13 1340. That's also open 8:30 to 10. In fact, it will be one of those counsellors that would triage your call and put you in direct contact with a colleague that could best respond to your request. That number is really for patients and families. It can help them with advice on the where to go. It can arrange bookings within the DASA service, and they also provide a telephone counselling service. So they really do provide a broad cadre of services that are available. I think I've already mentioned the Know Your Options website, which is aimed for your patients to be able to work out if they have a problem and if they have, what to do about it. But for you as health clinicians, all the DASA services in terms of where they are and what they have available, but also clinical guidance is available on this URL, and that's a hyperlink that when you get the material, you'll be able to get access to that. But if you Google DASA services for health professionals, that will bring it up. DASA is also in the process of offering academic detailing. They have nurses who've worked in the clinics for many years who are very familiar with all the clinical services available in the state, as well as evidence-based clinical approaches for managing the common conditions that you have. And it's possible to book access to them to come to your practice and provide clinical advice. And DASA is also in the process of developing an online booking system, so you'll be able to book your patients in that you want to refer to DASA, directly online, but that's work in progress and will be available soon. And I'm sure when it is, Chris Holmwood or one of his staff will ensure that you're aware of it. If you want to go to one of the outpatient services, as you know, there's one in McGill at Stepney, DASA Central. That's the fax number as well as the email address. We have a clinic out at Northern and Elizabeth, and also one down the south at Morford Vale. So you can make direct contact through a fax referral to them. And the best way of getting guidance on how to do that is that the primary healthcare networks in South Australia have developed health pathways. And the health pathways already have clinical guidance on a variety of conditions, mental health, as well as drug and alcohol. You can see that there is guidance there for a variety of mental health disorders, as well as how to do screening and brief intervention, the stuff that I've mentioned, using the assist, managing alcohol and opioid withdrawal, and how to get people into medication treatment for opioid dependence. There's work in progress that they're doing. They've got other things that they're currently in development and will be available shortly. And we know that there's a strong association between substance use disorders and mental health, but there's also a strong association between substance use disorders and behavioural problems, including problem gambling. And in fact, I'm working with the Vietnamese Community Association at the moment to develop intervention and care for that community, as well as those from Africa and other Asian countries, because their base has been broadened considerably. Okay, so the way to get into health pathways, if you haven't registered already, is to go to that URL there, saproject.healthpathwayscommunity.org, and register. If you've got any questions or things that you're uncertain about, you can get in contact with Veronica. As I said, happy to make the presentation available. So we have a few minutes left, and I just would open the floor for any questions or discussion or comments or feedback or whatever you would like. If you could type them in, we can share it with the group and have a discussion. Okay, so I've got some very nice feedback there. I've been asked, could I comment about alcohol dependence and driving? What's our obligations, particularly when completing fitness to drive? And what does the alcohol assessment involve? Yes, so For people that have got alcohol dependence that are still drinking, you have an obligation to notify the Registrar of Motor Vehicles, and they would then be formed to make an assessment. The assessments, as you know, used to be done by DASA, but are now done privately and independently. The guidance, the federal government and the state government, Road Transport Authority, have provided clear guidance about how to go about doing the alcohol assessment, and that is available as a downloadable document. What I will do is I will make a copy available to SAPMEA, and they can provide that to you, but I'll also give the link for everyone so that they can get access to it. I've been asked about, it seems that people can go to DASA at Glenside, then discharge themselves when they wish. How can we help these people develop the commitment to continue? That's a really good question. Alcohol and drug dependence requiring withdrawal treatment is not a condition where we would hold people against their will. So it is quite right that some people will leave early, they'll lose the result, and that can be a variety of reasons. Internal conflicts within the unit, unable to manage the severity of the withdrawal symptoms, cravings that become overwhelming, outside problems that are becoming urgent and they feel more important than their current situation. Those are one of legion answers that I've heard to why people have left. I think there's a lot of value in the motivational enhancement approach of Miller and Rolnick, and I reframe things all the time into glass half full. So the first thing I would be doing is congratulating them that they even tried, that they made it to the withdrawal service, and for the duration that they stayed. I then like to go back to, well, what was the triggers that led to their withdrawal, and what could have been done differently to prevent that from happening next time? Because whether it's internal drivers or external, if we don't deal with those issues, then they're likely to reoccur. And I see them really clustering into three dimensions. They're usually thoughts that they have, their feelings, which are usually negative emotional states, or there was some requirement of an actual behaviour. So I try to connect those concepts for them because they've often not unpacked them and thought about them separately. And what can we do to interrupt what are the drivers of the thoughts, the feelings, and the negative behaviours that have precipitated their premature withdrawal? It's clear to me, and it's interesting that it hasn't always been clear to people who've even worked in the area, that just because you haven't succeeded once doesn't mean you won't succeed the next time. So past failure is not an indicator of future failure. And in fact, if you think of your own personal experience with tobacco cessation, it takes on average a person 5 attempts before they're successful at quitting tobacco. Now, tobacco is the most addictive drug we know, but that's not to say that chronic relapsing disorder doesn't apply to all the others. So I'm also the optimist that just because you weren't successful last time doesn't mean you won't be successful this time. My job is to try and look at the antecedent prevention and work on them. So I'm being asked, am I aware of the waiting time to access appointments in DASA? Is there a list of psychologists with an interest? Unfortunately, I can't tell you the waiting list time in DASA. I don't know what that is at the moment. The Clinical Advisory Service, or ADIS, of course, will know because they're the booking referral system. They also have a list of psychologists with an interest in this area, which can be helpful and can be geographically linked to you. And that's something that I know DASA was working on, because it's a very common question that they get asked. And I've got some other nice feedback, and I thank you for that. Okay, so let me say that when you see people who have mental health disorders, always think substance use. They're often connected together, and often that the substance use disorder will precede the mental health disorder. But as I've said, it can also follow it, and it can also be disconnected. Moderate level problems for substance use really do respond to a brief intervention, and it really does only take 5 minutes. It is well within your skill mix, and there are a lot of resources on the Assist portal which can help you to connect to doing safe and effective behavioural interventions. The nice thing about it is that it works for a variety of other behavioural disorders. So it's a generalisable skill. So you definitely won't be wasting your time doing it. Always think of a step care approach. Don't just reach into the deep end for the prescription pad. I always try behavioural interventions, try to remove things, see if that improves it. Time it takes for change is measured in weeks, not hours or days. And if you add medication, the same thing is true. It's measured in weeks. And if things aren't working, or if you need advice, DAS is there to help. You can access the clinical advisory service, and you will get access to a collaborative, supportive person to help you think it through. And if you need to pass the person on, they will enable that to occur for you. So I hope that you found that interesting and worthwhile. I very much enjoyed the opportunity to be with you, and I think that SAPME is asking you to do an evaluation, which I'm particularly keen for you to do.
Thank you, Professor. That was a really interesting and informative talk. I'm sure everybody would agree. So if there's no further questions, that will conclude tonight's session. I would just like to reiterate, as per Professor's message about the Adelaide PHN's Health Network Central Referral Unit. The unit is responsible for triage referral to all primary care mental health service commissioned by Adelaide PHN Primary Health Network. When the PHN came into being in 2015, the CRU was created. Initially, this was commissioned out, and in July 2019, the service was brought into the PHN. Review of this referral rate from the CRU indicates that the referrals to drug and alcohol services were limited from the CRU. This led to a partnership forming between the Adelaide Primary Health Networks and the University of Adelaide, with a later training that formed to undertake the ASSIST tool, where indicated necessary. Preliminary data in the few weeks since this has been implemented suggests that referrals to drugs and alcohol services such as Northern Connect have increased this period. I've also they've included some slides for treatment services, which we will share with all participants as well as networks and websites that we can send through to you. I'd like to thank the PHN for funding this very important education session. And just to remind all participants, there is an evaluation at the end of this session, so please make sure you complete the evaluation form for us. Again, thank you so much, Professor. We hope you have a lovely evening. Good night, everybody.